Namaste. A very good evening to the FOGSI Gyan Pravah series of podcasts with luminaries from across the globe, which has been conceptualized by our very, progressive, Dr. Sunita Tandulwadkar, the President FOGSI for 25-26. And today we have an eminent luminary in the field of maternal and child health care and reproductive medicine, Dr. Evita Fernandez, who will be sharing her views with the entire audience. I welcome Dr. Sunita Tandulwadkar, madam, who has made her time from her busy schedule to be with us, and she is here every day at 8 p.m. to speak to us and give us the opening remarks on this podcast and to welcome our guest on the platform of Gyan Pravah by FOGSI. And as you all know, Dr. Sunita Tandulwadkar heads the Ruby IVF Reproductive Medicine unit in Pune, and also Madam is the founder and the director of the
Bharti, today's day is with you and Evita ji.
Yes, madam.
Thank you so much.
So I
Can I
welcome both of
request
you.
Dr. Barnawal to leave the podcast? The podcast is of Dr. Bharti Rajshekhar. I don't know why she also joined. I think everyone is eager to see Evita ji. Do you meet personally?
So now over to you, Dr. Sunita Tandulwadkar, madam, to give your opening remarks.
Look at the enthusiasm of chairpersons that they also want to do the podcast with Bharti today. And that shows the popularity of Evita ji. Thank you so much for coming on our platform and having you. You know, what happens is when we want to see you in the conferences, usually I see the group of your doctors. It's become rare to see Evita ji, but I need to congratulate you. You have done a lot to help the government or the India or to all our OBGYN to decrease the maternal morbidities and mortalities. You brought in the high-risk obstetric, a different compartment, explaining them to go to the more probably for tertiary centers. And there is a huge contribution of yours in teaching the good antenatal care, segregating the normal patients from high risk and how to tackle them and how to monitor them. So I always, not only India, but the FOGSI always will be in debt to you, Evita ji, for making innovations in the way we work in antenatal period. Thank you. Thank you.
Sunita, you've been extremely generous with your compliments, but gosh, no, thank you. We've just done what we thought we could offer. What worked for us, we shared. That's it.
It's really very important that we leave certain footprints on the earth or in the history of FOGSI or the history of maternal health. And you definitely did that. So thank you so much again. And I will enjoy your dialogue with Bharti from different link. Thank you.
Thank you, Sunita.
Bharti, now I will join that link and I'll definitely hear you from that link.
Thank you, madam, for being with us here and giving your comments. Now let's set the ball rolling and try to get the valuable inputs and guidance from the one and only Dr. Evita Fernandez. And as all of you know, Dr. Evita Fernandez is a very, very familiar face in the obstetric and gynecological domain of India as well as in the global scenario. So we all know that Dr. Evita Fernandez is the director and the chairperson of the Fernandez Hospitals in Hyderabad. And Dr. Evita took over the reins from her parents in the year 1985, and since then she has been spearheading these Fernandez hospitals into providing quality health care to maternity as well as antenatal and postnatal women. Fernandez Hospital has 3 units spread over Hyderabad, delivering around 10,000 women her year birthing over here, and she also has a nursing college. But what I would like to stress about Dr. Evita is she has been the pioneer in trying to bring in midwifery, in collaborating midwifery into healthcare systems, especially in the maternal and child healthcare in India. And from the year 2018, Dr. Evita has transformed her Fernandez hospitals into non-profit organizations and continues to train and to inculcate the natural birthing processes, respectful maternity services to all those women, and making this journey of parenthood very enjoyable, memorable, and something that is to be looked forward to. And welcome you, Dr. Evita Fernandez, to this Gyan Pravah series of us. So, to start off, it has been predicted by the year 2030 in India, we will be having around 35 million pregnant women waiting for birthing, and our healthcare resources are considerably strained. So, keeping this in mind, I would just start to a small introduction, because you have started the movement of midwifery to improve maternal and child health services in our country. So, just for the listeners, because many of us have this concept of midwife being maybe an untrained dai, or somebody who's been in a maternity hospital for 5 to 10 years, running behind obstetricians is a midwife. So, Dr. Evita, who would you call as a midwife, and what is her role in maternal and child health care?
Thank you. Thank you, Bharti. To begin with, thank you for inviting me. It certainly is a privilege. And you've been extremely generous in your introduction. Who is a midwife? Yes, that's a lovely question to start with, Bharti, because even today in circles, people consider an untrained dai as a midwife. But in today's world, when we look at a midwife, we're looking in the Indian Nursing Council, she has to be a nurse as a prerequisite, either a GNM or a BSc nurse. And after that, after 2 years of experience in maternity practice, she undergoes a very rigorous training of 18 months, where she meets global standards of clinical competence. After she's done this, she appears for an exam which is set by the Indian Nursing Council. She passes that exam, she gets registered as a midwife, and then you call her a midwife. In India, the term is nurse practitioner in midwifery. Globally, we address her as a midwife. So, in short, she's a healthcare professional accountable for the lives of two people, the mother and the baby. She is taught to take care of pregnant women who have no medical complications, what we would call low-risk healthy women. She's an expert in normality. So even if there's a slight deviation, she picks it up. And this is how midwives in countries that have invested in such a cadre have very, very minimal maternal deaths and neonatal deaths, because midwives recognize complications, either stabilize the woman or refer in time. So she's got to be clinically competent, Bharti. There's no second thoughts on it. Yeah.
So I think the foundation that this midwife is going to shoulder the responsibilities along with the obstetricians, and she is there as a safety tool that we could utilize to see that there is the reduction in, the maternal and the child health care is not compromised during this birthing process. Definitely, she should be a very good asset, especially in our country where human resources is one of the major factors contributing to the increased incidence of maternal and neonatal morbidity or mortality. So, what are the evidences, Dr. Evita, that you would like to put across? Because people may ask that what evidence do you have that a midwife could cater to all these normal birthing instances and pick up these problems and inform the concerned obstetrician as early as possible? So, could you just elaborate on that?
Yeah. If we go back to 2014, Bharti, the Lancet brought out a series called Midwifery, and they gathered evidence. And that is so overwhelming. It actually brought midwifery into the global scenario and into the spotlight. To sum up, they found that there are 54 positive clinical outcomes when women are cared for by midwives. And there's a recent study done in 2020. A whole group of people have done that. In fact, it's called Potential Impact of Midwives in Preventing and Reducing Maternal and Neonatal Mortality and Stillbirths. And what they've said, and this is a very, very brief summary, that if a country increases its midwifery cadre, even by just 25% over 5 years, you save 2.2 million lives by 2035, just by 25%. And 26% of stillbirths, 41% of maternal deaths. We're only talking about 25%. Yeah. So that's just a very tiny example, but the evidence is overwhelming. If you put low-risk, healthy women in the hands of midwives who are absolutely trained to global standards, you have found, and Cochrane showed this way back in 2016, that your interventions, unnecessary interventions, are reduced. And this includes cesarean sections. Your need for oxytocin is less. Your need for epidural is less. Your increase in natural births are more. And at the end of it, maternal outcomes. I mean, mothers are so happy because they have birthed normally. And outcomes of babies are, the ABGA scoring is improved because the midwife is a constant person.
Companion.
Yes. And the monitoring is absolutely superb with a midwife, which you and I can't do because we do 100 other things. We step in for a few minutes, assure the woman, maybe do a vaginal examination if necessary, but the rest of the time, it's the midwife. So when you have a competent midwife and you've got a woman with no complications, leave her in the hands of that midwife. And you focus on the mother that we are trained to take care. So the way we work, and this is, again, based on evidence, if you've got a trained midwife and an obstetrician, you work as colleagues.
Hand in hand.
We
work hand in hand.
Yes. And when you do that, oh my gosh, magic happens, because the woman gets the best care that she requires. So when a midwife says, hey, doc, we need you, I don't think this woman is going to come through. Then you go, you assess, and you may want to apply a forceps. And that's where our skills are needed. Can we apply a good forceps without causing any tissue damage? Can I do a good C-section in second stage of labor? Those are the skills that we have to develop. My midwifery journey, Bharti, has taught me that an obstetrician should not be doing any spontaneous vaginal births. In fact, in 2014, in Fernandez, we said, if an obstetrician is taking care of a low-risk mother and is there for a spontaneous vaginal birth, the woman is getting suboptimal care.
Okay.
We gave it a different
twist. The twist, yeah.
Yeah.
So, as you said, Dr. Evita, I think during my postgraduate days, we had a professor who used to tell me, learn to be a midwife first and then be an obstetrician. So, we were reading the midwifery book by Miles.
Yeah.
The Miles book was a favorite of
Right.
mine too.
Right.
And as you said, I think taking the cue from all the studies and the evidences that have come and the success stories globally, the government of India did come up in 2018 that we need to train these nursing coordinators, as you said, who will be around 90,000 are supposed to be trained by the government of India. So could you just tell us what is your role? I think I definitely know that you are one of the trainers who is taking this Government of India project forward so that we could have good, empowered, educated, and enabled midwives working all over the country. So, and you are the leaders of this movement, I would say.
Well, thank you. But I can't claim credit for that, Bharti. I just think we happened to be at the right time, at the right place. Telangana, was struggling with a high C-section rate. Apart from C-section, the commissioner of maternal health and family welfare in 2017 heard that we were training midwives in Fernandez. So she invited us. And thanks to UNICEF, that brought this partnership together, because public and private, we were thrown a challenge. We said, would you train 30 nurses and help me reduce the unnecessary interventions, including C-sections? But she said, Dr. Fernandez, I want respectful care to come back into our birthing rooms. Skills, I know you will teach, but can you change the mindset? And we took on that challenge because midwifery rests on two very basic beliefs. A midwife believes that pregnancy and childbirth is normal, physiological, and a joyous event.
Yes.
Second, the woman's body is built to birth, so she
True.
supports the woman. And the third, which is the fundamental, the whole care of midwifery rests on a foundation of respect.
True.
So you treat the mother with respect, keep her privacy and dignity intact, listen to her voice, support her in her choices, and be her constant companion there to assure her. So respect is the basic foundation.
Basic for any human being,
right,
wherever they are.
So when we started the course, we started with respect. And we said, how do we start? So we start first in the way we talk to each other,
Greet
the way
them.
we address to each other. So the first thing we said is stop standing up when we come into the room. Stop calling me ma'am. I'm Dr. Evita. Call me Evita, I have no problem. Call me Dr. Evita, but no ma'am. Speak with confidence. And then we began to talk about respectful care. And one day, when we did a scenario, one of them said, but that's exactly how I was treated during my birth. And the tears began to flow.
And that memories and the torment, it just
stays
stays with her for
you.
life. Stays with her for life.
So when she started her story, somebody else said, and this happened to me.
Me too.
So a class lecture that was supposed to be 1 hour, it went right through the morning, because out of the 30, 25 were mothers, and at least 15 wanted to share their birth stories. And we were all crying. It was a very emotional,
sad
moment. But that was the turning point. These future midwives realized this is no way to treat a woman. And that you combine it with knowledge, with clinical competence, you've got a cohort of people who will never allow disrespect and abuse in birthing rooms.
Very true.
So when the training kept, growing in the district hospital, and word got around that you've got this cohort of nurses in trousers and shirts, and they're really nice, the births began to increase.
Wonderful.
Delhi got to know about it, so Ministry of Health sent a delegation. They spent, I think, a day or 2 days talking to patients and doctors and everybody. They went back and then they set up a task force. And Fernandez was invited to be a part of that task force with many other organizations.
Yeah.
And finally, in December 2018, the government announced.
The government took up the project.
And we were so delighted because ultimately, Bharti, that's the most significant moment in a woman's life.
Yes.
And if at that point when she's most vulnerable, if we can give her that space.
She just needs a little care, love, and support. I think that's all she asks for. And joining hands in this movement, I think the FOGSI has also taken up the Manyata project where the nurses are being trained. And I think it's an extremely good because I have my hospital trained and the nurses have picked up a lot from this training program. And the women who come for birthing are also feeling very comfortable. And we don't hear any nasty words or any shouts from the labor ward department. I mean, that doesn't not only influences the mother who is there who's laboring, it also influences the mindset of the people around in the labor room, maybe the healthcare,
absolutely,
ourselves, even our own selves.
Yes.
The vibrations are totally different when we have that very good ambient surrounding within the labor room. I think that is what we have to learn from all these and take it forward to see that this birthing process is a pleasurable one. And along with that, I think the midwives also do play a role in the antenatal care, in the postnatal care, the lactation. They help them during lactation. So could you just elaborate on their roles in the antenatal period and the postnatal period?
Yes. The role of a midwife actually begins sometimes with preconception counseling, if the couple comes and meets her. But today, most of the midwives, they start engaging with the mother in the antenatal period. In fact, in Telangana and Andhra Pradesh, in the district, in the government hospitals, you've got trained midwives running antenatal clinics independently. In Fernandez, we have midwives running antenatal clinics independently. So their role begins at that period. They build that trust, and then there's continuity of care. So some of these mothers ask for specific midwives, but we work as a team. So you may get the midwife that you want, but
it may not be possible.
And then the midwife takes care of her during her labor, birth, and also looks at her the next day, helps her with care of lactation, care of the baby, and gives her contraceptive advice when she comes back 6 weeks later. Technically, the care is from the time she conceives till 6 weeks postpartum. And if she's working in a district hospital with the community, she actually gets to also speak to the families. So there's that huge bond.
She becomes a member of the family.
Absolutely.
And they will get any advice from her, even if it is not some concerned with maternity care. I think even if they have anything else like diabetes or any of the non-communicable diseases, they would always rely on this midwife, I think, to get the initial support.
I'm not so sure we've got to that point, but anything surrounding pregnancy, childbirth, contraception, lactation, care of the newborn, the midwife is involved, definitely. In fact, in Fernandez, I know of a doctor who had her first birth with a midwife, one of our senior midwives. Then she went to Bangalore. She was pregnant there. She came back from Bangalore for the midwife. She didn't meet any obstetrician. She called the midwife from Bangalore and said, "Are you still in Fernandez?" And she came and straight away just,
That's
and
good.
I thought
Wonderful.
that was a wonderful compliment to the midwife. And Bharti, we are no less. The human resource and the potential we have in our country is untapped.
Exactly.
If a nurse has the aptitude, train her to global standards, we can stand tall with any other country in the world.
Very true. They just need to have the aptitude, and we need to have the inclination to train them.
Yes.
I think
And
our
we
inclination
obstetricians have to provide that enabling environment.
Enable them for that.
And mothers are happy. The obstetricians don't have to worry about
Stressed
the tiny
out.
things.
Yes, they're not stressed out.
The whole atmosphere changes.
Yeah, I think
Ultimately, it's the woman who gets the care that she needs.
very true, very true. And as you rightly said, Dr. Vita, there's an immense potential in our, there's no lack of any human resources, provided we take them, enable them and empower them in the right way.
Yes.
Then we can definitely capitalize. And I think somewhere we did have a debate in one of our conferences recently, the state conference we had in Hassan. The debate was the place of midwifery-led care units in the present scenario. And I think listening to you, and of course, I've always been a proponent of midwifery, because it definitely goes a long way in helping the mother as well as the hospital at large. And so taking this forward, do you feel that somewhere, like you have trained many midwives and you are leading one of the midwife led care units in your Fernandez Hospital? So has this been taken up by many hospitals, either not the private, not the public, in the private led hospitals? Have you seen us embrace, the obstetricians embracing this midwifery led units?
Unfortunately, Bharti, that's where I failed. We've seen it grow in leaps and bounds in public hospitals.
Yes.
But in private hospitals, I'm desperately trying to push the concept. But what I have seen is a growing interest among the obstetricians to learn optimal birth positions. You know, how do I birth a woman in say, on all fours, left lateral, standing?
Sitting.
So these are things that we are now looking at and training women, obstetricians, in the midwifery philosophy.
Okay.
It doesn't matter to me if you don't have a midwife, but if as an obstetrician, you understand the philosophy and you offer it to the woman, then you are doing the best for that woman, because that woman wants that kind of care, which we obstetricians really are not trained to offer. We've not been taught to birth women in different positions.
True.
And once you allow a woman to set into labor spontaneously, empowered with knowledge, and she kind of responds to the pain and contractions, she will get into the position that she's most comfortable.
The most comfortable position.
Yeah,
Yes.
some of them may want to squat, some of them may want to stand, sit, or just
walk
get
around.
into all
Yeah,
fours.
all fours.
Yeah. And if we as obstetricians can be trained to birth these women in these positions, in one sense, we are actually offering them the midwifery philosophy. So all I'm saying is, if you're interested and you want to spend hours with a woman doing that,
Fine.
I have no problem. That's your choice. You're offering her the philosophy. But if you don't, and we are trained for something else, then get your nurses to be trained. And the whole idea is that you actually improve the quality of care, because not all women require instrumental delivery. Not all women need inductions. There is a growing concern about all these unnecessary interventions. Because we don't have that added benefit of this cadre of midwives to support us. So if there is fear, you would tend to induce a woman because you're not sure of being able to monitor her.
Yes,
because
that's
you've got,
that is what
you're caught with so many other commitments. And you don't want to take a risk. I can understand, because I've been through all that. But today we have an option. All I'm saying is, particularly in private care, the midwives make such a positive difference.
So I think we would, I think as obstetricians, especially when, as you said, we are all running single doctor-owned hospitals where you're the only obstetrician around, and you have to manage, as you said, the outpatient. You have to manage your gynecology. You have to do your obstetrics. I think this is a huge asset, because if you know that your midwife is trained and she's going to monitor that lady in labor, you can sleep well, because you know the moment there is a problem, she's going to call you immediately, and you
Yes.
can do the necessary intervention.
Yes.
And as I would say, I think obstetricians, we have been trained that there's a lot of medicalization of this natural birthing process, and that is where I think, as you said, the midwives can give them this being with them during labor and try to reduce the medicalization of the interventions, which definitely has been shown by evidence too.
Yes.
And Dr.
Yes.
Evita here, going a step further, now you said that you have been incorporating and trying to getting trained the trainers of trainers and the educators in the nursing colleges to get more and more midwives into the circuit. So, do you have any options like this for the private sector, where they can enroll, they can employ their midwives, nurses, and then send them across for a training program? What are the options
Oh,
available?
Bharti, I would welcome
True,
nurses
madam.
from
That's what we would all
any
like to have.
hospital,
Okay.
any hospital. In fact, I've been telling my colleagues who run their own hospitals, select 2 nurses that you can
Okay.
trust,
Okay.
whom you wish to nurture. Send them to us. We'll train them, send them back to you. And you start building this cohort. Because
So
if these 2 nurses come
leave.
back to you
Huh.
and they, you value them, you nurture them, it's unlikely that they will leave, and
They will mentor others.
yeah, because they feel valued, they feel
Yes.
respected, and then they will mentor others. And slowly you build this cohort for yourself. I'm convinced maternity services cannot be offered by solo practitioners. You'll
True.
burn out.
True.
And you will be forced to do these sections because
Yes.
you simply cannot
Cope
monitor
up.
every
Cope up.
mother.
Yes. You
Yeah.
can't cope
So
with
I
that.
can understand why a C-section rate will be high. But when you have midwives with you and you build that trust, your life is made so much easier. But more importantly, the woman is being taken care of in this collaborative model
Very
of
true.
trust and competence. Yeah. But in one of our hospitals, we have 10 birthing rooms, 5 being looked after by midwives, 5 where the complicated pregnancies are being taken care of by obstetricians,
Obstetrician.
midwives, intrapartum nurses. We've had about 1,800, I think, women go through the midwifery-led care unit. And our C-section rate among these women is 6%.
Wonderful.
Now, if the same cohort were being taken care of by obstetricians as we used to do 14 years ago, I'm sure our C-section rate would not have been
higher.
so low. Yes,
They've been
much higher.
Much higher.
So that's why I'm trying to get colleagues to
Yes.
embrace midwifery, because ultimately you're giving the best option for the women
True.
you serve. And you're working in a collaborative model. It's not like you've got 2 camps against each other.
I know it's
You're
not that.
working.
I think that's what we need to understand, that they are not subservient. We are associates. We are a team. And as a team, we can achieve more. We can
Yes.
achieve better, and life becomes more comfortable for the obstetrician as well as the parturient woman. And the midwife also becomes a very important aspect of this unit of ours.
Yeah.
And I think one of the factors for people, consultants doing OBG nowadays, we hear this word very often whenever you go, I'm not going to do any obstetrics. I do not want to do obstetrics. I will do reproductive medicine, or I'll become an endoscopic surgeon. I think that should not be the thought process of an
Yes.
OBGYN consultant.
Yes.
Probably it was because of this factor of thinking that they do not have a proper support system. I think that's one of the main factors saying that I don't want to be an obstetrician. So,
Yes.
what would you
Yes.
give? What is your message to all these people who think that obstetrics is a difficult road?
I feel sad when I hear this, really,
Yes.
because from the age of 16, I knew I wanted to be an obstetrician. And during my PG days, I would tell my colleagues, you know what? I'm not going to practice gynec. I'm just going to do obstetrics. And they said, "Are you stupid? You can't do that. You have to do both." But as it turned out, I mean, God blessed my life, and I ended up doing
And
purely obstetrics.
obstetrics.
And Bill, I mean, we were able to work as a team, and I had colleagues who loved gynecology, so they just took it
took
to a
over
whole
that.
different level, and we worked as a team. So I feel if you want to be an obstetrician, you need to have that aptitude and love for it.
Yes, true.
Because
Passion.
you have sleepless nights. You're called any time of the day. Though in Fernandez, over the last probably 15 years now, it's very rare to be called out of bed because they work as a team. And when you're on call, you're on call.
You're on call.
But the
Nobody
rest
else
of
is
the
disturbed.
days,
They're not
you get
disturbed.
time with your family. Unless there's an emergency and help is
Everybody is
called
called in for
then
help.
everybody,
Yeah.
which is part of the thing. So if you can provide that environment, I think you'll have fewer colleagues being anxious about doing obstetrics.
Yes.
Because there's so much joy in working as a team.
True.
You're there to stand by your colleague through the tough times, through the joyous times, through challenging times. And I
True.
feel that has really made a difference for us at Fernandez. You know, we work as one. So obstetrics is something that we all have enjoyed.
Love.
Really,
I have
really.
enjoyed it.
Yeah,
And
yeah.
there's no joy like that when you have the baby coming out and joyfully crying and the smile on its face is one aspect. And then later on, maybe after a few years, 15, 20 years or 25 years down the line, you're just walking down the street or you're in some wedding
Yes.
hall and you have these people coming, a tall, handsome boy or a beautiful girl comes and says, "You were the one who delivered me." I think that joy has no limits. And
Absolutely.
it's something that
Absolutely.
nothing can buy for you. Nothing on the
Yes.
earth can give you that.
Yes.
That's what I
Yes.
have learned in my 30 years of obstetric practice.
Yes. No, you
There have
you've
been
nailed
moments,
it.
there are
Yes.
moments when you do feel that you're going beyond or you're getting too stressed. But as you said, I think now is people, we need to have a team. We need to have a team of obstetricians as well as a team of enabled midwives.
Yes,
And,
absolutely.
and we
Yep.
have the human resources who can be trained, and the training process is already there. Training centers are there. We
Yes.
just need to, yes, centers are there. We just need
Yes.
to catch on to the train and get
Yes.
onto the train, I would say.
Yeah. Yeah. And if I can just add one more element, there's a third dimension today that's growing, Bharti, and that's the cadre of doulas. You know,
Okay, yes,
women who are
doulas in the
trained.
villages, yes.
No, not villages. These are women
Okay,
who undergo a very rigorous training. They are not involved in clinical decisions, but they are there to offer emotional, physical, psychological comfort
support.
for that couple, right? And it really, they play a huge role, particularly in high volume settings when you don't have enough midwives and you're struggling. And that doula is there with that couple. Wow, it's like magic. So the doulas also play a huge part in Fernandez. Right now, we have a team of 4 doulas. They're
Okay.
stretched, but they add to that whole environment of support for women. So that's another thing that's growing, and it's a whole new career. Women who've either been traumatized with a birth or who have enjoyed a beautiful birth want to become doulas.
Oh, that's wonderful.
Yeah. So they come because there's a great need in them to be with birthing women, either to make sure they've had a beautiful experience or to prevent a traumatic birth.
Traumatic
You know,
experience.
psychologically that you're traumatized.
So other than these 2 points that make them come to become doulas, are there any technical criteria to take them up for the training process?
Yeah.
And how many months is this training that's given to these doulas?
We last year, my doula team worked with the University of Hyderabad and now have it as a certification course, online course. It's hybrid.
That's wonderful. Okay.
Your requisite is 12 standard.
Right.
That's it. And over 2 years, there are, I think, if I'm not mistaken, there are 4 modules. And over 2 years, you're expected to complete the course. So when they launched it last year, we had 16 women.
Wonderful.
I think 10 were from Hyderabad and 6 were from across the country. Who registered.
Yes.
And it's very encouraging because these are women who are ready to embark on a whole different career.
True.
And who are so motivated to make sure that that couple has a joyous birthing experience. And it's not just birth. The doula is involved from the time the woman registers with a doula. She's on call 24/7 and follows up the woman postpartum for 6 weeks.
Postpartum.
Yeah.
So she's like a support system that is not
like
very technical, but more emotional, I would say.
Yeah, and she's an advocate for the woman.
Advocate.
Yeah.
I think this is something we need to also open our eyes to and take it up. That's very
Absolutely.
interesting. I think tomorrow I will just take down the application form and send it across to groups because there are many women who are interested to come into the healthcare system. For example, they would have wanted to become a nurse. They would have wanted to become a doctor, but due to certain circumstances, they would not have been able to realize their dreams. I think this is an opportunity for them to enter into that sector where they would love to work.
Yes. In fact, the second course is being launched, I think, in April. So I'll send you some details. So
thank you, Dr. Thank you, Dr. Evita. So, are there any handicaps or any sort of issues that you face during this training process? Do they have any financial constraints or any sort of, or when they get the certificate, like these midwives do get a certificate, the doulas also get a certificate. So, is that an advantage for them when they go in search of employment outside?
Yes, it certainly is an advantage because if they are first registered with the Indian Nursing Council, they can work anywhere across the country. That's one. But we've had 4 of our nurses, or probably 5, who've gone abroad. And one of them is in Canada, who actually entered a midwifery course in Canada and is now a midwife there.
Okay.
3 of them went to the Middle East and they were employed as midwives. And last year, one of our midwives here went to England and got a job as a midwife.
Wow.
So with the because you need to aim for global standards when you train them, Bharti. So if they leave you, and at times they will, because why would you stop somebody who's going
they have
to
some necessities or opportunities. Life is, it never has any fixed rules.
Yes.
There are no
so
fixed
they
rules.
go with that training and you're actually helping them get better jobs because midwives are in shortage all over the world.
Sure. Yes.
So if they go out of the country, they will definitely get jobs with that. Now, the problem is in private practice, if we can value a midwife and accept her as a separate cadre, a midwife is between a nurse and a doctor.
And the obstetrician, in between.
Nurses generally take orders. When a nurse becomes a midwife, she's changed her profession. She now takes charge.
Okay. Yes, that's a good one.
It's a big
transformation.
Big leap. Yeah, it's a whole new profession.
A responsibility, and she feels that she's in charge of this, and she has to do well.
Yeah, and she's accountable. She's accountable.
True, she's accountable. So I think that is what we have to improve the maternity and child health services in our country, whether it be the private or the public. I think we have to take up midwives, and we'll have to equate them as one of our own team and not just give orders, but we'll have to learn to
Yeah.
take information or take advice from them in most situations. They will tell us that whether she needs immediate care, because it happens. They will not let you stay at home or be out in the car. Say, no, doctor, we want you to come now. There something doesn't seem right. Something they are able to pick up those small nuances in the labor room, and
Absolutely.
and that helps a lot, and that confidence is there for us.
Yeah.
And along with that, you were speaking about the government training programs where the educators, they are trained over a period of 18 months. Could you
Yeah.
just, for the sake of our listeners, tell
Yeah.
us about how the training program goes on for the midwives?
In 2019, we were recognized by the government of India as the first national midwifery training institute for the country. And so we had the first cohort of nurses. You have to be an MSc nurse to become a national midwifery educator. So we have 30 MSc nurses from 6 states of the country. And they spent 6 months with us. Now, remember, MSc nurses who teach in nursing colleges don't actually work in the clinical side.
Very true, very true. They don't work.
Yeah.
Yes.
But to be a midwife and to teach, you have to be clinically credible, because essentially teaching midwifery, it's an apprenticeship model. You are
Yes.
there, your trainee is with you, you are in the trenches with the soldiers.
Yes.
So you can't teach midwifery sitting in a classroom.
Sitting in a classroom, very
Right.
can't do.
So that was the first change with these senior nurses. So we had to actually teach them in clinical work.
So get
And it
into the
was-
trench first.
Yes, yes. So that was the initial challenge. And some of them said, oh, we've done 10 years, we've done 15 years. We know how to birth. And when they saw the first video of a natural birth and the midwife just standing, not doing anything, at the end of the whole movie, this video, they said, you are teaching us not to do anything. It was, it was such a different
Yeah.
attitude, because see, Bharti, I had to unlearn so much.
True,
of
yes,
what
because we have
I
been
was
taught. Yes.
Yes. And we changed childbirth practices in Fernandez 180 degrees. So when we went through that transformation, we realized what we were doing with these MSc senior nurses. So the first cohort spent 6 months, totally clinical. They went back to their hospitals and we continued. Excuse me. So on Zoom, we continued the mentorship.
Mentoring them. Okay.
And our educators went across to the States to spend time.
Well, that's an excellent effort you have put in, and I know, as you said, it's a very difficult journey, because it has been ingrained, I would say, that she has to be in lithotomy, she has to be in stirrups, and we have to say push every contraction. The whole labor, everybody is saying shush, push. Like the Department of Labor Room itself gets a different tagline. It gets a different tagline because we're always saying push,
Yes.
push. So I think this has to come out. And you have been known for your innovations in maternal health care, and your birthing pods is something very interesting. And we did get an opportunity to see it at the recently concluded AICUG in Mumbai also. So I would like you to tell us more about it.
Yeah. When we started midwifery training in Fernandez in 2011, we were buying water.
Okay.
Because the government wasn't supplying water every day. So we had to buy water. And the midwives from England came to Fernandez to teach. And they had all volunteered because they realized that there's this crazy obstetrician who's actually training midwives, and they got excited. So when they started talking about water births, I said, rubbish. We buy water. This is a luxury. Half my city, people don't have water, and you want me to birth women in water? Nonsense. But as I read more and more, I realized that hydrotherapy was the simplest non-pharmacological analgesic
Analgesia, exactly. Very
you
true.
could offer to birthing mothers.
Yes.
And then I said, Evita, stupid. So we bought our first pool from London. It
Okay.
had to come all the way, and we spent enormous amounts of money. And Indy, who's the British midwife of Indian origin, left the NHS to join us and helped us, with this whole training and all the other work that we've done. So she helped us introduce the first water bath. And after that, there was no looking back. I
Okay.
said, no, I need to change. And now we have, I think, about 10 pools across the hospitals. And hydrotherapy is the first step, Bharti. Not every woman who's in the pool will birth in the pool. I mean, there are certain...
Yeah, I know, they just need it for some time.
Yeah,
There for
but
some
just
time.
that sheer
Relaxation.
buoyancy, yeah, it
The
just
relaxation.
helps, yeah.
And as you...
So that led us to say, hey, we can't have pools at such a high cost. Women should be able to access this. So we did some R&D, and now we've hit this lovely template. And I'm hoping that with more and more people buying, we can bring the cost
Bring down the cost.
further.
Bring down the cost.
Yeah,
True.
because I feel no woman should be denied this. And that's how we got into innovations. Yeah. So we set up a Section 8 company just to get this innovation going. Yeah.
And how is the acceptability by women? Do you demonstrate and show it to them? And
yes, during antenatal classes, you talk about hydrotherapy, you talk about water baths, and we also have women walking through the birthing room.
The unit.
Yeah, so they see the pool, so they know that there is something like this, and generally get people to consider it. It's how you actually, I don't want to use the word sell, but how you convince a mother about non-pharmacological options of pain relief. Yeah.
And coming to the non-pharmacological methods, I think labor companionship is still not caught up in our country. We still don't allow the men to enter the labor room. It's taboo for them. Don't you think that this needs to be transformed?
Absolutely. My God, if there's anything I ask for at every conference, I say, please, please have a birth companion. I mean, that's the single most important factor that has helped reduce unnecessary interventions. The constant presence of a birth companion has removed fear, has reduced the need for analgesics, reduced the need for oxytocin, reduced the need for instrumental deliveries, increased normal births, decreased C-sections. Just the presence of a birth companion. And more importantly, Bharti, it's a basic human right.
Right, very true.
It's a basic human right of a woman to have a birth companion.
And I think the trust factor also improves, goes up immensely when you allow them inside. They know what's happening around, what's the midwife doing, what is my wife or my daughter doing inside. She's all alone there with an unknown person. That apprehension is gone, and the girl feels very comfortable. The lady feels very comfortable when her own family member is with her.
Yes.
I think that's another transformation we need to all inculcate in our obstetric practice.
Yes, if there's any change I would ask my colleagues to do is make sure, promise yourself that no woman will birth without a companion of choice. That single change will produce huge, huge positive results. And the other thing, Bharti, which I realized, the minute you bring the husband in, everybody, your staff, become very respectful.
True, very true.
You change the way you speak to the woman.
Yes.
Your whole
movements
act improves.
Your movements different.
Yes.
Everything
and then
changes. Yes.
Your quality of care improves because now you're on display. So you really, want to do your best
best and
It's
impress.
all, yeah,
One is to impress them. The other thing
Yeah.
is you don't want to do a mistake and that you get
Yes.
noted and then you're
Yes.
reprimanded for that
Yes.
or you're known for that.
Yes.
I think, as you said, put your best. You're going to put your
Yes.
best act there in front of
Yes.
all the spectators.
So there are many advantages, really.
Yeah,
And
I do allow,
Oh,
since
I'm so
almost
happy.
25, 30 years, there were
Yes.
times when the family would say, oh, no, we will not let the husband go in, the mother will go in, the mother-in-law will go in. I said, no, the husband, I think, I mean, it depends, of course, it depends, it's by choice. But given a choice, the woman would always like to have her
Yeah.
husband with her, though in between her mother or mother-in-law, sister would come in. But she feels very good when her husband is around her.
Absolutely.
That's what I
In
have
fact,
observed.
In fact, one of the first questions in the birth plan during antenatal is asking the woman, who do you want?
Whom do you
Who
want?
do you
Whom
want?
do you
Yeah.
want to be with you?
Yeah. And you may have the odd time when she says, I don't want my
Yes,
husband.
yes, very true. She doesn't want. She says,
And you need to
I'll just
respect
have the
that.
nurse with me and I don't want anybody else.
In fact, one woman, she wanted a VBAC, and she was in one of our hospitals. And she was so determined. She had attended childbirth classes and everything. So the midwife was with her, the obstetrician. That's collaborative care because it's a VBAC. And at one point, the mother said, why are you going through this pain? Just go ahead and have a C-section. The woman was so upset. She said, I don't want you in the birthing room. Please go. And she pushed the husband out, she pushed the mother out, and she said, I just want my midwife
Myself.
and the obstetrician. And when I heard that, I was actually quite taken aback. But we had to respect her choice.
Her needs.
And she went on to have a beautiful vaginal birth. But you see, that's another learning lesson, Bharti. Do we listen to the voice of that woman? It's so important to provide that whole environment
so that she
where
makes
she
her
feels
choice.
her
She's the one.
choices.
She's the most important person there.
Yes.
Yeah, and this scenario, I think, happens very often. And very often we see the increased incidence of C-sections. They will say that my daughter is in labor for 12 hours or my wife is in labor for 14 hours. They choose that she undergoes a C-section, though she's still ready to go ahead and wait for a few more hours. She is ready. This scenario is quite a common scenario. I think that's where we obstetricians or the midwife there need to talk to the family. Talk to the family and convince them and tell them that everything is on the right path. Don't push yourself on her. I think that also creates a huge impact.
Yes.
And Dr. Evita, we are almost coming to the end of a session. And on a personal note, I would just ask you, what are the most favorite things in your life? These are a few of my favorite things. Just to make it.
The thing I'm most passionate about is long distance driving.
That's
just
wonderful.
Get into a car and drive right off to Goa, to Cape
So
Comorin,
you drive yourself?
Yes.
That's wonderful.
And
Adventurous.
that's one of my passions. Of course, music and books is something that I love. Yeah.
Those are three beautiful things which can keep you going. I think that's the secret of your enthusiasm, your mindset, and that wonderful, wonderful vibrations and spirit that's been, and you have been mentoring thousands and thousands of obstetricians. And I have had the privilege of being at your center for a couple of days to learn the nuances of labor analgesia and the labor room protocols. And I think many of us have done that. And I think it has been a wonderful, wonderful discussion with you. You have put across the care, respectful maternity care, midwifery, labor companionship, which are very, very simple things, I would say, to incorporate in our practice. Do not require much of any instrumentation or investments, except a few months of good training and certification and mentoring later on.
And change in mindset.
So what would be your take-home concluding remark for today?
I would make a fervent plea to all my obstetric colleagues. Open your minds and your hearts to have professional midwives in your birthing rooms. and work with them with mutual respect and trust. And trust me, magic happens. Your whole world changes.
That is such a magical thought for the day, Dr. Evita. We thank you very much for being with us today and
Thank
looking
you,
forward to meeting
Bharti,
you
for
again.
the
And the road
privilege.
to Hassan is a wonderful drive. We have,
I will.
please
I
do
will
drive.
take you up on that.
Sure, definitely. And we will drive together to
Sure.
further meadows and pastures, which will give you much delight. Thank you
Sure.
very much for being with
Thank
us
you.
today.
Thanks
And I
so
thank Dr.
much.
Sunita Tandulwadkar for giving me this excellent opportunity to be face to face with such an eminent personality of our part of the globe.
Gosh.
Namaste to all my dear listeners.
Thank
And
you,
namaste to
Bharti.
Dr. Sunita and Dr. Evita and the entire technical team. Have a good
Thank
night.
you. Thanks a lot for the privilege. Good night. Yeah.
Good night.
Bye.
Good night.
Yeah.
Bye.